Hi, folks. Welcome back. Here we are with our next recorded lecture. I'm your instructor, Victor Paviana Bundesguerra, and here we are in Philosophy 110, Intro to Phil. And yeah, in these set of slides, we're going to be talking about euthanasia, sometimes called mercy killing or assisted suicide. So let's go ahead and get into that. Again, we're in our unit of applied ethics. We've already looked at ethics and we've looked at the idea of reparations. That was another applied issue. Here is another applied ethical issue. Applied ethics, obviously, they're still ethical. We're still talking about right and wrong. But like in our previous unit, we're looking at ethical theories. Now we're trying to grab those ethical theories and look at specific issues like reparations, like euthanasia. And our next topic is going to be abortion. So keep that in mind. But outline for these slides, right? We're going to go ahead and look at taxonomy or give a bunch of definitions of euthanasia so we know what we're talking about. We'll look at the American Medical Association, their code of conduct. As we're going to see, spoiler alert, they're going to be against the euthanasia. They think it's bad. We're going to look at what I call or not what I call, but what America called the Brittany Mater effect, and there'll be a short video regarding that. There'll be arguments for and against euthanasia that we'll briefly consider. And we're mostly going to be looking at the Rachel's piece for these set of slides, namely active versus passive euthanasia. Rachel's going to argue that there's essentially no moral difference between the two. Right. I think not in these slides, but in the next set of slides, we're going to go ahead. I see that I don't have them here, but in the next set of slides, we're also going to go ahead and see what Velman has to argue. They're not in these slides, so I'll go ahead and put them up for you folks to have as well. But with that said, let's go ahead and get into it. So euthanasia, what is it? In short, it's the painless killing of a patient, sometimes referred to as mercy killing. However, there can be a lot of distinctions in the eyes of the law, so let's get into it. Passive euthanasia is sometimes referred to as letting die or pulling the plug. So the doctor ceases medications or ceases treatment so that the patient dies. That's it. You just let them die. Think of in the trolley problem, right? You're just letting the 5 people die if you walk away. That would be an example of that. This is usually accepted and deemed permissible by the American Medical Association. They don't seem to have too many qualms with this. Active euthanasia is taking action in order to bring about the patient's death. This is much more controversial. And in this, there can be voluntary euthanasia, which is legal in a few states, and we'll get into that, versus non-voluntary. Obviously, that will be murder, right? If the patient doesn't want it, doesn't consent, that's bad. That's illegal. You don't do that. But let's go ahead and look at the voluntary active euthanasia distinctions, because there's even more distinctions under voluntary active. There's physician assisted, where you provide as a doctor help in administering the lethal drug, but the patient themselves must take it. So maybe you give them as a doctor the lethal syringe, but they themselves have to inject themselves. And finally, there's physician administered, where again, the patient wants it, it's active, it's voluntary, but they themselves, maybe they're paralyzed from their whole body, maybe can't even swallow. And if they're paralyzed from the whole body, maybe they communicate with their eyes or a button press, I don't know. And they say they want it some way, or they communicate that they want it, obviously. But they need help with administering it, then you as a doctor administer it. You're the one that injects them or gives them the pill in their mouth or whatever. This one is pretty controversial as well. But the one that has taken up the most conversation within the last decade or two is physician-assisted suicide. So for the purposes of the next slides that follow, we're mostly going to be focusing on that one. So real quick, what does the American Medical Association? They're a supervisory organization. They're the biggest supervisory organization in America and the United States, and they supervise the profession of physicians, of doctors. Well, they are against it. They say, look, it's understandable, though tragic, that some patients in extreme duress, pain, such as those suffering from maternal, painful, debilitating illness, may come to decide that death is preferable to life. That's unfortunate, but in these cases, physicians should permitting or allowing doctors to engage in euthanasia would ultimately cause more harm than good, according to them. Euthanasia is incompatible with the physician's role as a healer. Remember, doctors take a Hippocratic oath, which says that they should always promote and preserve life. Euthanasia seems to be going directly against that promise that they made. It would be difficult, furthermore, or impossible to control, and will pose serious societal risks. euthanasia could readily be extended to incompetent patients and other vulnerable populations. What does that mean? Incompetent patients and other vulnerable populations. You're talking mostly about neurodivergent people, people with mental disabilities, and they're talking mostly about the elderly, vulnerable populations. You might be saying, that's ridiculous. How could that happen? But we'll get into it later on when we look at the development piece. America, Pacific California, does have a very, very bad history of eugenics and sterilization and going and abusing vulnerable populations. I'll just leave it at that for now. Instead of engaging in euthanasia, the AMA says that physicians must aggressively respond to the needs of patient at the end of life. Physicians should not abandon a patient once it is determined that a cure is impossible. Respect patient autonomy, but if they want euthanasia, don't give them that, of course. But must provide a good communication and emotional support, and finally provide appropriate comfort, care, and adequate pain control as they begin to die. But again, don't kill them. Don't assist them in dying. Don't assist them in suicide. So that was kind of the final word in most of California up until the case of Brittany Maynard in 2014. So Brittany Maynard in 2014, she was a recently married Bay Area resident up in Northern California, and she was diagnosed in early 2014 with a ravaging brain tumor, but vowed she wasn't going to endure the agonizing end that can occur with her type of cancer. After surgery didn't stop the cancer and doctors gave her 6 months to live, Maynard packed up and moved with her husband and 2 dogs to Oregon in order to access life-ending prescriptions under the state's Death with Dignity Act. So, it's a little morbid, but imagine where you want to die. When I imagine my death, I want to have a peaceful death. I want to be at home, comfortable on my bed, and I want to be surrounded by my loved ones. And notice, right, when I was telling you that, said that I want to be at home. I don't want to be in some random state that I don't really care about or that I've never been to. That's not how I want to die. I want to die at home, surrounded by people that I've grown up with. But she was denied that. She was not allowed to die at home. She said before she died, and she did die, I do not want to die, but I am dying, and I want to die on my own terms. With her prescription bottle tucked in her purse, she told the camera, I will not tell anyone else that he or she should choose death with dignity. My question is, who has the right to tell me that I don't deserve this choice? So she and her situation sparked a big debate in California, and it gave rise to current California law, which allows for physician-assisted suicide. This is how it works. Adults 18 and older must make 3 requests of their primary doctor for an aid in dying prescription, twice verbally, 15 days apart, and once in writing. They must be mentally and physically able to request the lethal medication and take it themselves without anyone's help or coercion. Doctors are not required to issue a prescription and cannot be held liable for refusing a patient's request. What they take is not specified by the law, but I think for most plays it's a barbiturate. But just a second though. Here is a video of her. Obviously, content warning. It is very emotional. This is a dead woman that you're looking at in this video, and the video should be down below. Go ahead and watch it. So remember, at this point, we're repeating the same slide, right? The AMA Code of Conduct says that this is bad. California is essentially going against the AMA here. They are not agreeing on this, but the California law is protecting this, is protecting physician-assisted suicide for now. Now, there are many arguments for and against the idea that a doctor should be able to deny a patient physician-assisted suicide. So sometimes in medicine, we call this idea conscientious objection, or it's basically saying, no, I'm not going to do that. The question I want to sort of consider here now, right, is should a doctor, if they have a patient that says, hey, I want to die, can a doctor tell the patient, no, I'm not going to help you with physician-assisted suicide? Chances are a lot of you think that you have a right to die and rights to your body. But does that entail that a doctor who may not feel comfortable is therefore forced to engage in physician-assisted suicide for you? Now, there's arguments for physicians being able to say, no, I'm not going to help you with active euthanasia. These arguments say things such as it goes against their duty beneficence to promote health and well-being. This from the Hippocratic Oath. You might say that it might lead to a slippery slope where then it hurts vulnerable populations or incompetent patients. This is what the AMA, the American Medical Association, says. And as we're going to see in not this set of this lecture, but the next one, David Villman on the top right here, he's basically going to argue that people misunderstand what dignity is and that we shouldn't give people the right to die in medical settings. As we're going to see pretty soon, there's also arguments against physicians being able to object. The idea that if a patient asks you that they want to die, then you should abide. Namely, patient autonomy, that their goal is to die and you should help them with that. That's what they want. You should help them as a doctor. You might say that there's no slippery slope because they have to be in the right state of mind, and you have regulations to make sure that it's not generalized to the elderly, for instance. And of course, we're going to see James Rachel's argument that there's no difference, he's going to argue, between active and passive euthanasia. So if you would be forced to give passive euthanasia, you should also be forced as a doctor to participate in active euthanasia. But with that said, folks, we're going to go ahead and pause it right here for today. In our next recorded lecture, we're going to go ahead and look at the Rachel's piece. But with that said, folks, I'll see you next time. Bye-bye.